Who went to California? Where'd you go?
Thousand Oaks by Chico.
Oh, did you go down there for the fire? Oh. How was that?
Relatively uneventful.
Well, that's good.
Increased to 3.
I was talking to Dallas upstairs.
Hey, you're live.
Alright. When, we'll talk today. Don't stress. I'm telling you right now, I'm looking at my email right now, and I have.
Oh, yeah. There we go. Get myself to
Is this somebody's pal?
struggle.
I don't know. Yep, here it is. 26, 27, 29. That's Friday. Got nothing on Friday. So 26th.
There was another one just for like the first.
Brent, are you teaching this afternoon?
Yeah.
Okay.
Yep.
Plan on our own.
See, it's so good.
Wrap up on resources on our own.
Builder help.
Patient care
What is that here?
which is all these guys.
What, oh, it's right by, event center.
That's Thursday, right?
Thursday, yeah.
That's
It's just west of both of them, exact same big parking lot.
Well, no, the 27th? That's
Yeah, Friday.
two. That's
Today.
today.
How many hours will it take you to get there?
So,
I
December
got
first is when.
too bad that way. Well,
That's
actually,
December 1st. That's Saturday.
right.
So I got ambulance equipment, driving operations.
Zero efficiency.
I got all these people.
McConnell.
Not us.
One on that one.
And here it is. December 3rd, which is gonna be
On Monday.
Monday. Which will be here late.
Not late nights, I mean,
I know.
Third, December 4th.
12 o'clock.
CPR skills, medical good stuff. Normally actually skipped for one day.
That too.
Yeah.
Fourth.
What's the 4th?
Tuesday.
I have one portion of last name, Menlo.
That's all I got in my account.
Okay.
So just go and bring it up. That's what that's all the invites I got.
Kathy.
Okay. Well, I told him that. He said,
Curtis.
no,
Oh,
we're
no.
supposed to be there the first.
Kathy
So,
and Carter.
I don't know. I'm just repeating what I've heard.
Yeah, he was looking for help.
Oh, okay, we have one person logged in.
The other time.
Okay, cool. Can they see that very well?
Well, it's what's on the phone here
Yeah.
in the red.
So text me if they see it. Text me if you see it all right.
Probably better tell them who you are.
Well, they should have heard. Right?
That's Captain Burge.
No, you would.
We just want to make sure that this is streaming correctly. Yeah, it's catching your screensaver somehow.
Oh, is it?
Mhm.
Yeah,
Yeah.
it's in the background.
Well, let me see if I can get rid of that.
Hello.
Morning, Cora.
My apologies.
Do you need that, or did you get that?
Tetrix.
Yes, I got,
Why did I come? No. Teasing.
Right?
no.
Would you like me to teach?
You're right.
Sure.
Sure.
Yeah.
Right, Julie?
Sure, hop right up there.
Well, I'll show
No,
you if
I'm
you're
saying
on,
you
because
could
I
too.
think you're on, I've already
I'll pass
seen
on
it.
that.
All right.
I don't have any kids, so that's.
Oh.
You probably have more experience than that.
I've
A little bit
delivered,
of
Covered
experience.
straight down your
I've
mouth.
delivered a few.
Yeah, that's awesome. I've not actually delivered, but I've been there with my sister-in-law, and then also, I've been with my children. So,
Yeah.
You were there?
For that?
I was. Isn't that awesome?
Imagine
I
that.
know. Including a preemie, so.
Oh, really?
Yes, 32-weeker.
Oh, wow.
Now, are you
It's a
seeing,
little early.
No, that was better.
okay, let's do that one then.
So, we've done the whole neonatal.
Four
and-
something?
Thank you. It was 4:30. Good job. They, did the ultrasound the day before and said 3:15, so when it was 4:03, we were really happy.
Oh, yeah.
Perfect.
That's better.
I don't see anything behind there. Okay, so real quick, PAT numbers. We have a deadline on those. That's gonna be, needs to be done before Thursday. That's my deadline. Or you will not be able to test. And that means you'll have to test somewhere else, like at Mount Mevo or UVU or University of Utah. So get your PAT numbers done today. Let's see. I'm also going to show you right now, this is who I have. You see that? So I've got these people done. So Kelly Long, Brandon Morgan, Bethany Bitter, and Kenny Aldridge. A couple things, if you saw the email, just make sure you change the testing center to UVU and the program director to Steve Allred. That is because we're still in under UVU's blanket. And thanks to Kenny, yesterday he kind of worked out some of the bugs in it when he got through, and he sent some feedback on the email. I think you got yours. Did you send yours?
I did, but it won't let me change the thing to UVU. It says if your EMS program is not listed, please contact your program director.
It should be listed on there.
Yeah, try and do it today. Whoever hasn't done it today, before we leave, let's just make sure it's done. Jeanette over UVU is automatically putting you on the roster as soon as you get it done. Okay? All right, cool. All right, no background?
I don't think so.
Okay. All right, so before I get going on obstetrics, this is a touchy subject, so I'm just going to warn you now. I try to have some humor in this, but don't be offended. I have pictures, so that's the way it goes. Most of the pictures are in the book, but it's going to be about anatomy. The one thing we do know, if we want to go by recorded history for the last 10,000 years, birth has been something that happens every day, and it's actually considered a BLS skill, really, because we do this all the time. But there are some complications, and we'll go over that. The big thing is This obstetrics is gonna be something that you'll probably be tested on a few things, and it's gonna be about some of the things that go wrong, like placenta previa or abruptia or whatever. We'll go over that. But anyways, hope you like it. There's a lot of slides, but I have to look and see things, and an APGAR score. You got to know your APGAR score. So after we get through today, hopefully you'll have a good idea of your APGAR score. I'm going to blast through a lot of it, but the movies and the I feel are very helpful. So you're going to see some live bursts today. So again, don't be offended. It is what it is. All right. So let me turn this guy on. All right, so we're going to talk about, I just thought that was kind of a cool picture, a bunch of ladies putting their bellies together. All right, our lecture, Where Babies Come From. There are some graphic pictures, the mechanism of injury, okay, or what happened, all right. So this is what you get as far as the book shows you. It shows you the reproductive system, and you will have to be a little bit dialed in about the ovum and the unfertilized ovum and the ovary. Women are born with everything they're going to have, and their monthly cycle puts out an egg every month. Everyone good with that, right? Don't have to go into too much about that. So just when you, today when we talk, let's talk about things you don't know. And I'm sure that all of you have the birds and the bees discussion, right? Okay. All right, so this is a labeled vagina. The only thing I usually tell my students in the college is they need to understand that that anatomy. I'm just gonna, the one thing that I was on a delivery with one of the guys that work here, and it was a long time ago. So we're talking maybe like 14 years ago, and he saw this gal that she was having a baby, and she was doing her, she was having her contractions, and he literally got down at the end of the gurney and put his face like, I don't know, maybe 3 feet away from her vagina to watch this cycle go through. And I'm like, dude, what are you doing, right? But I don't think he'd ever really seen it. So, or he just didn't understand that, and it was really kind of funny to watch that. All right, so let's talk about normal pregnancy development. So we have that release of eggs from the ovary. The egg travels down the fallopian tube. Intercourse within 24 to 48 hours should result in fertilization, and that usually occurs in the fallopian tube. What happens if it fertilizes the fallopian tube and doesn't move from there? What kind of problems can it cause there? Yeah, we can have an ectopic pregnancy, so that's bad. So, but the fertilized egg will implant in the uterus, and then pregnancy begins. But that's one area where we might have a hiccup, and they didn't know, right? And the problem is if you have that development in the fallopian tube, then now you're going to have bleeding in the pelvic region it'll get big enough until it ruptures. Okay, so here's your cartoon picture of kind of how that works. This is the way it should work normally. You have your ovulation, you have your fertilization, and it should happen down in the distal third of the fallopian tube, and then you have that implanting in the uterus. This is normal. We like this. This is what you want to have happen, right? Okay. There's other couple of structures that we need to know about because you're going to see those. You have the placenta, the umbilical cord, and the amniotic sac and fluid. So a lot of times what we see when we get called, someone's sac is ruptured, right? And so at this point, we have a lot of fluid. If we have an umbilical cord sticking out first, we're in trouble. and so is she, and so is the soon-to-be pediatric. And then our placenta should be on the sidewall of the vagina, not in front. And sometimes it will plant itself in front of the vagina, so that it can't come out. So these structures can cause us problems. All right, so usually the placenta happens about 3 weeks after fertilization. It's really rich in blood. It transfers heat, oxygen, gets rid of carbon dioxide, which we do in our breathing process, right? It gets all the nutrients to the baby, and it carries away waste products and starts the process of hormones for the fetus to survive and maintain that pregnancy. All right, so normally the placenta should be up higher, okay, and in the uterus. All right, so we already talked about that. Transfers gases, nutrients, waste, gets rid of it, hormone production, protection. All right, so then through the placenta we have the umbilical cord. And why this is important, because once you have the birth, right, we're going to have an afterbirth of the placenta, and so we should be expecting that. And a couple things we don't want to do: we don't want to pull on that. We don't want to pull on the cord because it will deliver on its own. But the cord on a normal delivery is the life's blood for that pediatric or that fetus at that point. However, it also can be one of our biggest enemies because it can wrap around the neck. Okay, so that is something we're kind of looking for. But it is like a little rope structure. It's about 2 feet in length. It has, you might have to remember this one, 2 arteries, 1 vein. Okay? And then the 2 arteries return deoxygenated blood, which is opposite the way our whole bodies work, right? And the vein supports or transports oxygen and blood to the fetus. So this is one of those ones you might get asked a question on, and you need to know that it works exact opposite the way it works for us, okay? The high pressure and low pressure lines. So just remember, 2 arteries. It returns relatively deoxygenated blood to the placenta, and the vein transport oxygenated blood to the fetus. Okay. Now it shows kind of how that all connects and why that does, and it goes through the baby's system. I don't think you're going to get asked a ton of things on that, other than that it's working opposite the way we do it. Let's see. I kind of already got that. So this one has a bigger picture of what's going on with the 2 arteries and the vein. So we have that placenta. We have the 2 arteries that are you can see here, right? And they wrap around and go in there. And then we have the vein. And the vein is obviously carrying the oxygenated blood into the superior and inferior vena cava. And then you're removing your waste through the arteries. Just more pictures of this if you want to kind of look at it more, but this is in your book. All right, the other thing that we can do is what's important about the 2 arteries and 1 vein is that when birth happens, it's really hard to find a pulse on a pediatric, right? Well, where do you think you can find a pulse really quick? Right on the umbilical cord. So you can see if that pediatric's got a really good pulse rate. Well, I'll show you there's some other things of, poor deliveries, and your APGAR score is going to help you know if this is good or a bad delivery, but we'll talk more about that in a minute. All right, obviously then we have this amniotic sac that has tons of waters in there. It allows that development for the fetus, but it carries somewhere around 500 to 1,000 mils. So So keep that in your mind. That's like a 500 bag of IV fluid or 1,000 bags, so that kind of puts it into your head. So if we have premature rupture, then we have a possibility of an infection, and that's considered an emergency, so we can get them out and to the doc as soon as we can. I think we're all good about that. That's just kind of a rehash of it. So field growth and development. I'm going to go through some really good pictures on watching that growth, and you tell me. I mean, I think it's kind of cool to watch this. So in the first eight weeks, it's called an embryo. After that, it's called a fetus. There's other words too, like zygote, and so you may hear that too. Instead of embryo, they'll call it a zygote. But anyways, your embryo is inside and your fetus is outside. Everyone good with that? All right, gestation takes about 40 weeks, and they like to do 90-day periods as time starters. So you kind of have to know about the 40 weeks. You kind of have to know that there's 3 gestational periods. All right, so this is something you may want to kind of at least have a really good understanding of, because you'll probably be asked maybe something about this, but the first trimester is 1 to 13 weeks. And I like to kind of remember that because 13 is my lucky number. I don't know why it is, but it works for me, right? But after 13, that's kind of a very sensitive time where viability could be in question, right? But then the second was 14, so 13 is kind of a cutoff, and then 14 to 26. I think right now the best we can do right now is they can save a fetus somewhere around 19 to 20 weeks.
Stepson's 22 weeks, 3 days.
Yeah.
1 pound, 9 ounce.
Yeah. Yeah. So 20 weeks is viable with a lot of medical care, right?
Yeah, he spent 3 months.
Yeah. And a huge hospital bill, right? So preemies, that's a whole different story, but anywhere between that 14 to 26, this is a time where we really can make a huge difference, and the fetus is viable. And then after that 27th to 40 weeks, then you're in your 3rd trimester. Here's kind of some pictures. I'm going to show you this. I don't really like this as much, other than it does give you kind of how what is being developed in the first, 2nd week, and 3rd week. Again, you call it what you want. I love watching this, and I think it supports my evolutionary process in my mind, because you're female first, and then you turn to male. You look a lot like a different animal, and then turn into a human. It's kind of cool to watch. I just like watching it. But the biggest thing is you can see your central nervous system is really being developed in 32 and 38 weeks. The heart, 6, 7, and 8 is being developed. Limbs, lower limbs, a lip, your ears, your eyes, and teeth are kind of after the 9 weeks. I don't think you need to know this, but I just think it's interesting to look at, right? All right, so now I'm going to go with I have some pictures and what it should look at. At the first month, baby's about a 1/4 inch in length. Okay, so that's not very big, right? The end of 4 weeks, very small. Your placenta starts to develop. A single fertilized egg is now 10,000 times bigger than the size at conception at only a 1/4 inch. Not very much, right? Okay, so that's what it looks like. You have, at 35 days, the eyes have developed, you have your lungs developing, the heart is now in place, and your arm buds and leg buds and limb buds are starting to develop. Okay? 49 days, it's looking more like a little alien, still. Now it's starting to look more human to me, right? 2-month period, now you have, your fetus is about 1 1/8. So now you're about that big, very small, right? And mom doesn't show, but the female, if you were a female or a male, right now your sex will be assigned to you, and this is where your organs are about assigned at month 2. So you're either male or female around month 2, and I just think that's kind of cool. Baby's moving, but usually mom can't feel it. You've got eyes, nose, lips, tongues, ears, teeth are all forming. The heart is now functioning. Okay, so this is about the end of the first trimester, 12 to 13 weeks. Now we're 2.5 to 3 inches. Okay, so now we're that big. That's kind of cool. The fetus now has nails, arms, hands, fingers, legs, feet, toes are fully formed, eyes are almost fully developed, and most of their organs and tissues are being developed at this point. Heart rate can be heard at 10 weeks. So we got actual heart rate going at month 3. So the first trimester, a lot of growth, a lot of changes going on. The second trimester, we're now 6.5 to 7 inches, so now we're about as big as a hand, right? You have the fetus now does have sucking reflexes, swallowing reflexes, may catch them sucking their thumb. They'll have tooth buds are developing, sweat glands are forming, fingers and toes are well defined. You definitely can identify the sex. They're bright pink, transparent though. Sometimes they have a soft downy hair at this point that's developing. And you can recognize them as a human at this point for sure. So there it is. There's your end of the first trimester. Looks pretty good at this point, right? So, you know, whatever laws you want to follow, this looks pretty good to me, pretty viable. At the end of 4 months, still pretty viable. That looks great. And then second semester, trimester, sorry, semester, geez, holy cow. You're about 8 to 10 inches long, about 1 pound, and mother can feel movement at this point about month 5. All right, so 20 weeks, this is viable. If born right now, with the technology we have, we can pretty much, you know, depending on how severe or any other complications are not loaded up on the fetus, this is a time where we have a really good cutoff on being able to make a difference. And there you go. That's what you'd be seeing at 20 weeks. That's pretty cool, I think. All right, at the 6-month mark, you're getting eyelids as part of the eyes, and the fetus can hiccup, and anywhere between 11 and 14 inches long, so we're about 1 foot long at this point. Third trimester, so month 7, we have taste buds, organs are maturing, skin's turning from pink to more red, and at 7 months, they're considered premature, but very viable. 32 weeks, you could be anywhere between 16 and 18 inches long, maybe around 4 to 6 pounds. Fingernails now extended beyond the fingertips. The kidneys are mature. The lungs are starting to mature. However, right now the CNS system is now kicking in. So there's a huge, tremendous amount of central nervous system development at this point. And then month 9, This is good. Lungs are mature, and the baby will now turn and settle into the pelvis with the head down, which is what we want. We like that. All right, this is kind of cool. So like 4 seconds. I just thought that was kind of cool to watch that. She took a picture all the time. What is amazing to me is how the female bodies bounce back most of the time, right? They bounce back, and it's crazy. All right, so what is our general management of what's going to happen? We find at this point we're going to have that birth. If the birth is not imminent, and you take care of that patient, often can be limited, and there's some basic things we can do if there's no birth and it's not imminent. So we don't. As QA guy, you get certain complaints, all right, from some people, and usually it's the other firefighters complaining about the other firefighters. But I know that's weird. That might happen, right? But one of the complaints was the person that was treating the female pregnant, the female that was pregnant. He probably treated her a lot like he would have treated his wife, and was a little bit too intimate with the way he was touching her. And so at this point, be very careful on how you approach the delivery. Most females at this point are going to be 100% trusting in you. They want your help, but if all you need to do is you need to only visualize at this point to see if it's imminent or not. And I'll show you pictures of what imminent looks like and what is not imminent. Okay. All right. So in the absence of any distress or injury, we just put them in a position of comfort. Why left lateral recumbent? You guys tell me why. Yeah, it's all about the superior and vena cava, right? So if she's laying on that, then she's starving the pediatric and herself for oxygenated blood. So the book doesn't really talk about it as much, and we'll go in that in just a second. But ECG monitoring, oxygenation, fetal monitoring. We don't really have a lot of tools in our ambulance to do that, right? But if mom's doing good, then we can pretty much see that the fetus is doing good. And based on that assessment, we might do some IV access. The only time where this becomes null and void is if there's been a car accident or trauma. At that point, we can't see. We don't know if we've had abruptia from the placenta. We don't know if there was a seatbelt that maybe pressed too hard or caused injury or damage or whatever. So in any kind of trauma, if the fetus is left without oxygenation, fetal demise is up by 50%, and so otherwise they're going to die. So you don't want to scare the mother, but if there's been a significant injury or significant mechanism where you see that, and I'm only saying that right now just so that, because the book doesn't really go into it, always err on the side of having them have a full exam, which we can't give in the pre-hospital setting, right? Okay. Okay. So when birth happens, it's put in stages. So we have we have the first, second, and third stage. I'm going to show you a video on this, but it's really important that there are 3 stages. This may be a question on a test on how many stages, but the first stage is that the contraction until the cervix is fully dilated. Okay, so the biggest thing is they're showing a picture of the cervix here, and that dilation that they're looking is for 10 centimeters, for that to be 10 centimeters in length, so that's time for delivery. we, in the pre-hospital setting, maybe when I helped deliver my own children, I was able to feel that cervix and feel if it was 10 centimeters or not. We don't do that in the pre-hospital setting. And that may be something just, some people might get a little bit too rammy on this one, but that is not our place. And the other thing too is there's a huge liability stuff. Those doctors have some liability insurance that is out of this world, right? I probably shouldn't say, but I mean, I have my own $1 million policy, my own health policy. I can pretty much slander anybody and I'm good. So, but there's nothing that protects us in the pre-hospital setting. Nothing. If they want to sue. Okay, so then we have the second stage, and this is when the face, or you're showing the head, and then the third stage obviously is the birth is done, and now we're waiting for the placenta. All right, let's see.
Well, I found, Baby Center is a really big resource for me, almost like a friend. It follows me all the way clear back through preconception, pregnancy, through delivery, through new mommyhood.
So this doc goes through the stages, I think, on this one.
In the weeks before birth, your body slows down production of the hormone progesterone while increasing production of other hormones, including prostaglandins, which soften the cervix, and oxytocin, which triggers the uterine muscles to contract. True labor contractions are rhythmic and painful and grow consistently stronger. As the long vertical muscle bands of the uterus tighten, they pull the cervix open. The strong muscles at the top of the uterus push down and release, guiding your baby toward the cervix. The mucus plug, a collection of thickened cervical mucus that sealed your cervix shut for 9 months, may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones of his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning. With several more pushes, your baby's face, shoulders, and body will emerge. In the third and final stage of labor, your placenta detaches and is expelled. With your baby's first breath, the incredible journey of birth is complete.
Okay, I just like that because it kind of reinforces your stages, okay? We'll have some more videos here in a minute. Okay, so again, just to kind of put that all together, this is your cervix and your cartoon picture of it from dilated to fully dilated. So I think everyone's good with that. They use some words like effacement, dilation. These are kind of words you may want to be familiar with, but in the pre-hospital setting, she's going to tell you that, and then you're just going to remember. Okay, signs of labor. You may have contractions. There may be some bloody show because that mucus plug has come out. And then water from the amniotic sac, and I think we've already talked about that. All right, so here's a couple things that cause us some concern in the pre-hospital setting, okay? Not a lot we can do about it. However, what can we use for seizures? Versed, right? But the problem is, Versed also goes to the fetus. However, mom going into full seizure, losing her oxygenation because she's not breathing, is, I think, far worse than making sure that the fetus has not compromised with oxygen. So the biggest thing is, and we'll talk about why would they have seizures? We'll call it preeclampsia is not having a seizure, but ready to have one, and eclampsia is having seizures. And it is a real medical emergency because of what it does to the fetus, and we'll talk about that in a minute. Vaginal bleeding, some is good, but a lot is not. So anything over 10 cc's should cause us some concern. So get a 10 cc syringe. If it's more than that, then we're concerned. Again, a visual inspection of that is sufficient. Trauma, we already kind of talked about that, but I really want to put it out there. Any kind of trauma whatsoever, always err on the side of treatment and bringing them into the ER. And then miscarriage. I've seen this done several different ways, and some there was one time we didn't like the way it was handled, but sometimes she'll go into the bathroom and miscarry into the toilet, and the kids will be there, and then you take mom away, and the fetus is still in the toilet, whatever. I would say retrieve that and bring it with you. I didn't like how that went at first, and I was like, hey, we need to do this too. Because an 11-year-old looking in the toilet shouldn't be something we're dealing with. So just be aware of that you're going to probably have some issues with retrieving the fetus or retrieving whatever has come out in the miscarriage. Do you guys need something?
Yeah.
I just think it's still Jolie for scenarios. It's really on two of us.
Yeah. Well, how about take John?
Huh?
Take John.
Or John. Yeah.
Where's John?
Morgan.
No, John.
Oh, he's upstairs.
Ask him if he'll fill in for Julie and these guys.
Okay. We'll still need one more person. And Rob is tied up. Wayne is at an appointment. And Underwood's unavailable. And Dallas isn't here.
No, yeah, Dallas and Underwood are on doctors. Okay, well, you guys can choose to miss this or not, but
Just talk to me, right?
okay, all right. But have John help out for sure right now.
Go to Kiyoshi, didn't
Kiyoshi, yeah.
He's upstairs.
Oh, is
It's on
he?
my duty.
Yeah, we could use Kiyoshi.
Working in staffing office and everything.
I used to work for OBGYN.
Did you?
Pretty good concept.
Okay, all right.
It's 3 down, so.
So these are the things that we're concerned about. These are the concerns that will go from a normal call to a shouldn't and getting call, as I like to call them, right? All right. So let's talk about seizures. We have preeclampsia, and that's preeclampsia. Blood pressure will increase by a lot, and they'll get swelling of their extremities. A lot of people will have to go on bed rest, and the other thing too is our lights in our ambulance can cause a seizure. So just be really careful. Preeclampsia patients, if we're going to transport them, no lights and sirens unless it's really bad, and try and keep them calm and as good as we and quiet as we can. Eclampsia occurs late in the pregnancy, but that's when the seizures start, and we don't like eclampsia. But again, you're going to have elevated BP, a lot of weight gain, swelling in the face and the extremities, and a headache, just because your blood pressure is going through the roof. And it would be normal to see someone with like 180 over 100. So it's pretty bad. Okay. So again, the eclampsia is related to the high blood pressure. What are we going to do with that? We're going to transport and monitor vital signs. Seizure treatment, we'll transport on the left side and give them take care of their airway and their O2s and transport. That'd be your initial assessment unless they don't break out of their seizure. Vaginal bleeding can mean two things, and so I've got them highlighted, but one is abruptia because the placenta has separated prematurely instead of at birth, so it separates early, which means now my fetus is now starving for nutrients and oxygen, right? So we don't like that. And then previa is it develops over the mouth of the uterus. So again, there's nothing in the pre-hospital setting we can do except for vomited, extra diesel. Okay, so that would be something we'd be thinking about that. So any kind of blood, and there's nothing showing, I'd still consider this an emergency and get them to the proper place. And a lot of the ERs will not take you to the ER. They'll say, pass through us, go to the Women's Center. So be aware of that and know that would be the appropriate way to deal with that. You're going to pass right through the ER into the Women's Center. So here's a couple of pictures, side pictures. I try to just show you as many pictures as I can because it's just, it seems to be, it just helps me learn better. But you have a small abruptia, a major abruptia, really major abruptia, or complete. This is bad. And then previa, you have your normal, and then you have your previa in front of the cervix. Okay, everyone good on those two? We know those two words. We know what they are. Cool. Are you ready for a break? You want to push through? Half hour more? Okay, all right. Okay. So again, we're going to do our BSI. We're going to do our initial assessment and take a good history, and then we're going to have to start asking words about, how many kids have you had, how many kids have you had alive, and we'll talk about what those words are in a minute. Transport on the left side, and then is a sterile pad and sanitary napkin that we can put there to for the bleeding. Again, this would be the only time you would now visually see, and then you would pad. And we do that with all of our trauma dressings that we have. And then save any tissues if there is any. All right, so we talked about this a little bit, but ectopic pregnancy is bad as well. This is where the egg divides in the fallopian tube. It's implanted outside the uterus. There is a lot of abdominal pain. There would be some bleeding. A rapid weak pulse would be a later sign in that. Now we've ruptured, and now they're bleeding inside their pelvis. And low blood pressure is a very late sign. So our Starling's law with heart, what comes in has to come out. If they're losing blood, then the heart's going to try to increase to keep blood pressure up, and then once late sign, it's going to go into asystole or PEA. PEA is a really good sign of I ran out of blood, because the heart's wanting to do the electrical thing, but has no fluids to push through it. Okay, so watching at this point, when we have somebody who is bleeding at all, we should be looking at vital signs closely every 5 minutes and see what our blood pressure and heart rate is. And we'll talk a little bit more about what's normal and what's not, but during the third trimester, she brings on an extra at least a liter of blood. So she's going to have higher blood pressure, a higher heart rate anyways, and we don't notice any change until she's lost at least that first liter. And females only have about 4 liters to lose anyways. So during pregnancy, they can get up to 5 liters of blood, but then, and we don't notice that first liter missing, and then they deteriorate very rapidly. So you gotta kind of watch that. So 5-minute vital signs are most important at this point. Okay, so locations of ectopic pregnancies, they show some places where they outside of the uterus wall, in the abdomen. I don't even know how that happens, okay, but it does. Sometimes in the ovary, down the tube, and then on the cervix itself. So those are considered your ectopic pregnancies. All right, figure out the patient care on this. don't, figure out if you're gonna transport or not, which you probably should. Prevent shock, care for shock, and nothing by mouth. Okay, so miscarriage and abortion. So delivery before the 28th week is called spontaneous miscarriage. And then there's induced abortion. Some results are deliberate. My ex, I think between 1 and 2, she miscarried, and so they did a D&C, which is really called an abortion, right? And they wrote it in that, and she was pretty much worked up on everything you can think of when they did that, and she read abortion in there, and she just freaked out. I'm like, okay. And then I gotta tell you, my gynecologist, OB guy, he was a jet fighter in Vietnam, and so he comes out and he says it just like this. He goes, you know, sometimes babies are like on a potato chip factory, and sometimes bad potato chips come out and we just pluck them off, and then good potato chips come out later. I'm like, oh, if you would have said that to my wife, he was good, but I was like, holy shit. So make sure you wipe your face off, and you are very use your kid gloves when talking to your pregnancy patient. I would never refer to it as a potato chip. That just won't work for me, right? Okay. Signs and symptoms: cramping, pains, bleeding, moderate to severe, and then discharge. And it could be like a mucus plug, and you really can't see too much, or it could actually be a somewhat developed fetus. So again, try collect that tissue if you can. Sometimes they flush it, and you can't do anything about it. Again, vital signs: oxygen, control the bleeding, transport, save tissues, emotional support. Seriously, that emotional support is probably it's as important as making sure the vital signs are in the right area. Okay. Blunt or penetrating, so falls, assault, collisions. This is our biggest reason for fetal demise right here. So always treat this as a red alert. So always. Okay, so when you look at assessment, the pulse rate is always 10 to 15 beats faster than normal. They have that in volume blood, and we've already talked about that. Shock is hard to detect early because they have extra blood, and the shock comes later. And then if there's bleeding or wetness, this is the time to go ahead and inspect, right? And sometimes you can just ask them, and they'll say, yeah, I really have a problem going on right now. Okay. And then figure out what the mechanism of injury is. Like sometimes I've been in and you guys know the difference between this, and it's nice to be able to talk to people who've seen this, but someone's maybe not been rear-ended, but that someone kind of hit their back end of their car and left very little damage, right? And they pulled over the side, and they said, oh, we've been in an accident. Well, and mom was in a seatbelt. No one's neck hurts, nothing like that, but still, you would consider it trauma, and at this point, you're practicing medicine. How bad was that hit? Try to figure out, was it a full stop or what was going on? And then make your decision based on that. Again, take care of if you're going to resuscitate somebody who's dead. That may be something you'll be doing CPR on someone who's been in a really bad trauma. I would work them all the way and let the doctor make a call on the fetus. So O2 IV, suction, transport, and emotional support. The other one is stillbirths, which it seems it's a lot like a miscarriage, but they die in the womb. Sometimes you can do continued resuscitation, and we'll look at some pictures of somebody, some peds that may be pretty close to dying. And you need to record times. Again, so you can tell stillbirth. There are obvious blisters, there is a foul odor, there could be some tissue deterioration, very, very soft head, and you're not feeling any pulse in the umbilical cord. So if it's obviously dead, you don't resuscitate. If there's pulmonary cardiac arrest, this is something we can probably fix in the pre-hospital setting because we can do airway, breathing, circulation. But imminent death, just try to do the best you can to provide that life support and do your transport. Okay, so now preparing for delivery. So you're assessing the need for the emergency delivery. Your first decision is say, should I stay or should I go, right? You need to ask a couple things in your assessment. And so these words, gravida, para, antepartum, gestation, grand multipartum. Okay, so gravida, all current and past pregnancies. And the way I try to remember this is gravida is every pregnancy they've had, including their miscarriages. Okay? Para, number of pregnancies viable to delivery. So para means how many times were you actually made a parent? They're alive. That's how I remember that one. So para means how many kids have you actually had that are living in your house that didn't die when they were 3 or whatever. Antepartum is that time before delivery. You're going to hear that term, but it's not a term that you're going to have to memorize. But the gravida and para, that's pretty important to know in your assessment. So make sure you kind of put that in your head. So how many pregnancies have you had total, and how many have you been actually a parent of? Gestation is that time where the 40 weeks or 9 months, and then 7 deliveries or more. That actually is fairly common in this state, right? Okay. Multipara means I've had 2 or more deliveries. Natal is that prenatal. That's the word connection of prenatal vitamins. Nullipara has never delivered. This is a huge difference from someone who is grand multipara, right? Because that's the nullipara is probably the delivery is going to be longer, probably. Whereas someone who's had 5 to 7 kids, that delivery is going to go pretty quick. And then prenatal is at or near birth, and postpartum is after delivery. And you probably will deal with someone who has postpartum depression or something like that. So again, after delivery, depression. The premigravida is pregnant for the first time. The premipara gave birth once, but like I said, just the para means you've been a parent. And the term 40 weeks gestation is going to be a normal thing. And you can actually look at them and you can see where they are, which I actually like that based on their belly button and where the bulge is. Okay, so a couple things happen. They do not menstruate. They have an enlargement of the uterus. The genital tract change, breasts enlarge. They have GI system problems. A lot of them will start peeing all the time, and their back will hurt, and they can't sleep at night. Cardiovascular system is increased to support the baby. The respiratory system is increasing so that you get more oxygen, and they have metabolic changes. Mostly that's because of their hormone changes, that enlarged uterus, increased blood, and the major demands on the system. So I think it contains 16% of the mother's blood during pregnancy. The uterus does. The respiratory increases oxygen consumption by 20%. Just gee whiz, whatever. But just know, 20%. 40% in tidal volume that they need to take more in, right? Slight increase in respiratory rate and diaphragm pushes way upward. The cardiovascular system puts out more blood. Their blood increases almost 45%, or could. The heartbeat increases 10 to 15. Blood pressure in the second trimesters go down, but then goes up. And sometimes you can have supine hypotensive syndrome where their mother lies supine and then their blood pressure goes down. And it's about 5 months of pregnancy. So that might be something, they'll tell you as soon as you walk in the door that they have that issue. Nausea and vomiting is common. Delayed gastric emptying is common because they can't, the baby's moving around and their GI system is not moving. And then bloating and constipation. So your kidneys have a major increase blood flow to them. You have glucose spilling into the urine. Your bladder's displaced, and they can rupture because of trauma, and then urinating a lot. Pelvic joints open and loosen. Gravity shifts to the front, and their posture changes to accommodate for that, and then they have lower back pain. Okay, now we're going to go to normal delivery. Why don't you guys take a 10-minute break or a 5-minute break, and we'll get into this. Let's see if I can get coverage on those days. Just in fact, yeah, get coverage on those days.
I'll see if I can.
Yeah, have someone trade, and then come on in. And we'll pay those. Okay.
I'll see if I can get some.
In fact, I will put an email out.
Okay.
If it's on C platoon day, then
Yeah.
find coverage, and we'll take care of it.
Yeah, 'cause I gotta.
So, I'm not getting my number.
And it won't let me change the class.
It
where
won't?
is. No.
So.
Who do we have to call?
So under this, I don't have the number. I've got confirmation application, and I verified that it's under Utah Valley. But I think it's saying, on this other thing, it's saying like it's waiting for confirmation. So is there something?
Yeah, so she's gonna put you on the roster.
So maybe we have to do that.
There is a way to look at your PHE number, but,
So it's saying.
So is there anything else I need to do? We have to wait.
sometimes the PHE number might take a few hours to come up. Did you just do it today?
Yeah.
Okay, so it might take a few hours.
Maybe
Did it yesterday?
she has to verify that it's before it comes up, it doesn't say,
No,
because
it won't change.
waiting for it to be submitted.
Do I have to call somebody later?
Yeah, let me do.
Verification of has submitted.
Yes,
Maybe
so,
that needs to be
in
done.
fact, I'll check before we leave, and I can see if your PHE number up. Okay.
So we do our practical first, written.
Your written, you'll have to just take on your own, you can take it at,
We
up
can
here at
just
Slid,
schedule
you can take it.
schedule it, right? Or
We
the
can
testing
schedule it,
center
yeah.
or whatever.
We can do that.
Yeah.
So we could take the full 90 days to get ready for this,
Seriously,
because
right.
it's 90 days from the day you put it out to
Yeah.
yesterday or today.
Mhm.
And you have to have it scheduled and tested by then.
Yeah, I have to put you on there, and you can go take the test, but,
When can we schedule? You have to put us on?
yeah, I have to, as soon as, we're almost, we're almost 2 weeks before the end of the semester, so we'll have you take
They
care of
have
it.
to be paid.
If you fail, we'll take care of you for the first time.
I would not confess that, oh my goodness. I need more money after my college grad.
I pay for the first,
Okay.
you're on your own for second and third.
Okay.
Well, you only get third, yeah, so I'm already paying for the first one, and if you fail, I'll pay for the second, and then the third, you're on your own.
Okay.
Okay. But you're not going to, because right now you're gonna get the LCS ready. I do have I'll talk to you guys about before we leave. I do have a practice one just to knock you on your knees that I'm gonna send out via email here, and then I'll send out the key, maybe in a few more days.
It's self-grading.
Yeah, and then you can self-grade it, just
Awesome.
to see, it's 100 questions and it's hard. But, there you go.
What's that, our final?
No, it's one that
No.
I'm just getting used to taking another 100 questions.
Came back and said it's 28 and time and drive a lot, drove a lot,
That's good.
Pretty much like the first one. A lot of driving, very little.
yeah,
It's too bad
it's just
you
like
don't
you said,
Yeah.
mobilize faster because my son and his wife live in Chico, super close to where they were. So it was scary, like we all broke out that Thursday. Are you guys okay?
Did they evacuate or anything?
They didn't have to, part of their city did, but they were right next to the interstate, so they still in apartments.
So they're far enough in that they
The car
didn't.
and the.
But still.
It was like, yeah, we came outside, it was terrible smoke, and it was like, well, just get some stuff together, because my daughter-in-law has a photography business, and so I said, just make sure you've got all of your, hard drives, everything ready to go, just in case, so, I guess not.
great stuff.
And actually Oroville, you heard about Oroville, right?
Mm-hmm.
So Oroville, it moved over that direction, and that's where they've been doing huge efforts for some of the kids and people, and that's where her parents have their houses in Oroville. So it was really refreshing to see, so a little bit glad her parents had to get them back in.
Pretty wild.
Yeah, that's crazy. Any good calls out there?
No.
No coffee?
No, thank you,
Water,
sir.
monitoring
Trying to
you?
quit, yeah.
Water?
And so you heard about that one?
No, thanks.
Twenty